Deanna, or whatever her name is, I can't even pronounce it. Do you know where she left off last week?
Yes. Hold on.
That's okay. I sent her an email, but she never got back to me to let me know, so I don't want to repeat stuff if somebody has the specifics of where she left off.
Yeah, I have a placing here. It was page 392. She left off with nails.
Okay, so you guys went through surgery guidelines and then got into the integumentary.
Yes.
Okay, perfect. So I will pick up from there. We'll finish 14 and then we'll go into musculoskeletal. And I double checked with the adult education, and there is school next week right up through Friday. So we will have class as normal on Thursday unless there's a storm, she said. The following week, which will be the week of Christmas, there will be no classes, but classes will resume the week of New Year. So you'll have 1 week off, and then we'll start back in for the new year.
Yep. That's
Okay, Karen, I won't be here next Thursday.
Next Thursday you won't be here?
Right.
Okay. So what you can do if you want is either shoot me an email to remind me, or I'll try to remember. I'll send you an email letting you know how far we got, and then that way you'll know what to get done before you get back.
Okay.
I won't be there either. That's my son's birthday, and I promised I'd take him to Disney on Ice.
Nice. That's next Thursday?
Yep, the 21st.
21st? Okay, so what I'll do is I will check with Amy, because if we're only going to have the other one, and I know she didn't make it the week before last, if she comes tonight, I'll check to see if she was planning on attending. If she's planning on attending, then I'll record it as normal for you guys. If she has something planned too, I'll ask Amy if it's okay if we just take the 2 weeks, or, I don't mind coming in to record it, but if nobody's there, it's kind of hard because I don't get questions or anything, so I try not to hurry through it, but it feels like it goes a lot faster if there's nobody actually there watching. It's kind of weird.
Yeah, the class, we went through the stuff really fast because it was just her and I, and we were face to face.
Oh, yep.
So I didn't really have a lot of questions because...
Yeah, I guess they had connectivity issues at the other places. They did not transfer the connection knowing I was not going to be here. So there was some issues, and that's why I sent out that email, because I felt so bad, but I was in the ER and I did not know if they were going to let me out in time. So first thing, in the morning, I made sure I had at least somebody to do the class so you guys weren't completely stranded. So.
Yeah.
All right, so integumentary and nails. I'm trying to think. She sent me, just check, she sent me an email, and I wonder if, that's weird. I know I had an email from her today, but it's not showing up on my phone. Little varmint.
Karen.
Yes?
It was kind of neat, just to give you tell you how she was doing it. It was kind of neat because she had us follow along in the CPT book, when we did that, and I felt like that was kind of helpful.
Okay.
I don't
Yeah,
know if it was just
usually-
because it was the surgery part, just so that we could kind of see what it looked like as we were reading. It was
Yeah.
kind of neat.
Yeah, because what I try to do is when we get into the individual chapters and it refers to the sections, I have you go back to the CPT book as
Yeah.
well, because you can always make notes, and you can always, of course, go back and reread in your textbook as well.
Yeah.
But yeah, when I give the code references or something, yeah, I try to tell you what page it's on so that you can see what it is. So, yeah, we will definitely try to do that.
Yeah.
All right.
I think
so,
it was easy for her because she said she does surgery coding, so it was like back in like nothing to her. She
right.
was slick.
Yep. And of course, once you get that habit of doing something like that all the time, it's practice, practice, practice. And I had somebody the other day, they did not, I guess they took the online course, not the physical course. They took the course but didn't do it like you guys. And they said it's like you're learning a foreign language, and that's exactly what you're doing. But the more you do it, the easier it gets. And some people, as you go through, I probably have told you before, cardiology is not my favorite at all.
Mm-hmm.
I don't like cardiology, and I don't know that you could pay me to code cardiology. But some people really like it. So as you go through the sections, you can get a feel for possibly what area you want to go into and what you want to code. Because, you've got primary care, which does a little bit of everything. You've got specialties, which are just geared towards, their specialty. So you got to get a feel for what you're going to, like to do. So what we will do is we will get started with the nails, which is on page 392 in your textbook. And in your CPT book, the nails start with the 117 codes, which would be on page 78. So the nail category, 11719 to 11765, these codes are trimming of fingernails and toenails, debridement of nails, removal of nails, drainage of hematomas, biopsies of nails, repair, and reconstruction of the nail bed. Now, when you think nails, typically, especially feet, you think podiatrist, and they do specialize in the care of the feet, so they use codes in this section quite a bit. But you still do have primary care and foot and ankle physicians that will also use codes from this section. The first code you see is the 11719, trimming of non-dystrophic nails, any number. When it says any number, that means that they could do 1 toenail or they could do 10. It does not matter. You are going to get paid the same amount for doing 1 as you would 10 or 12. No, you wouldn't do 12. So any number, you do not need to put how many toenails you did. It does not matter. The next code, the debridement, you'll see it says any method, and it's for 1 to 5 toenails is the 11721, or 11720, excuse me, and then the 11721 is for 6 or more. So when we code, we got to, again, read it carefully, but we want to make sure we're paying attention to the numbers, because if it says 1 to 5, we also do not need to let them know whether we did 2 or 5. It doesn't matter. If it says each, then we do need to let them know how many we did. So those are the 2 debridement codes. If you are dealing with Medicare, note that Medicare has its own debridement code in your HCPCS book, and that is G0127. So Medicare, in your HCPCS book, a lot of the G codes are ones that they recognize only. They have codes in there for colonoscopies, and of course we have regular codes in our CPT book for colonoscopies as well. But if you're dealing with Medicare strictly, you do want to check out those G codes in your HCPCS book just to see if there is one of those you should be using instead. Avulsion is the separation and removal of the nail plate. So those are codes 11730, and that says simple or single. And then we have 11732, which is each additional nail plate. And remember, if it's got the plus symbol next to it, it is an add-on code. So we always have our base code. When they do the removal of the nail plate in this particular code, they are preserving the root of the nail, so the nail does grow back in this instance. And again, because it says single, we would have to put how many we were doing, and that would appear in the units column on our insurance claim form. Do not use modifier 51 with nail removal codes, as there are two codes available, one for a single and one for additional. So what I did is right in my CPT book, right next to those codes, I would put no 51 needed. And that way, if by chance that was a question on my exam and they threw that modifier on those codes, when I looked it up, I knew that they didn't need the modifier 51. Subungual hematoma is blood under the nail, and you can puncture the nail with a needle, 11740, and they squeeze after they puncture, and that material will drain. Onchocryptosis, ingrown toenail. The nail grows down into the soft tissue, which causes pain and can cause infection. Sometimes they need to do an onchiectomy, which is removal of the nail plate and root. And again, here they anesthetize your toe and they remove the nail plate and the root, 11750. And here your nail will not grow back because they've removed the base as well. So if they remove the base, you are not going to have a nail come back. When we talk about fingers and toes, you can see at the bottom of the page 1414, we do have a grid for our HCPCS modifiers, which let us know what fingers and what toes we are dealing with. So here, again, make sure to use those modifiers when you are talking about fingers and toes. On 394, we have codes for excision of pilonidal cyst or sinus, 11770 to 11772. These are still on page 78 in your CPT book. These are located in your sacral area and most oftenly caused by, again, an ingrown hair. There's three codes: simple, extensive, or complicated. Again, we are not going to determine which it is. That is up to our provider. If your provider does not tell you, the only thing we can assume is we could assume it's the lower of the codes. If we do that and it was a complicated case, then we are losing reimbursement for our provider. So it's better if you can to query your provider and try to get an answer out of them, or to look at the documentation and see from there. For a simple cyst, they excise the cyst and suture the skin. If the cyst is larger than 2 centimeters, it is considered complicated. And some complicated excisions are very extensive and sometimes will require reconstruction. Introduction category, 11900 to 11983. Lesion injection, tattooing, tissue expansion, contraceptive capsule insertion and removal, hormone implantation services. So this would be, your lesions would be like acne or scar tissue, psoriasis, for example. If you look at the second code that's listed, the 11901, that's not an add-on code. So you report 11900 for an injection up to and including 7 lesions. And if it's more than 7 lesions, it's just the 11901. So you would not use both of those if you've done, let's say, 8 lesions. We then have some tattooing codes, 11920 to 11922. Tattoo is reported based on square centimeters covered. So this would be to cover a birthmark or a scar. You do want to make sure, and we talk about it if it wasn't talked about earlier in this chapter, sometimes you do need to know the conversion between centimeters and meters to work out your code, so make sure you have that written somewhere so you can do that conversion easily. We have subcutaneous injection of filling material, 11950 to 11954. This would be collagen or silicone dermal implants for a wrinkle treatment, and they are based on how much is injected. So if you look at the codes, it says 1 cc or less. The next code is 1.1 to 5 cc's, 5.1 to 10, and then over 10 cc's. And this type of injection is usually one that is repeated possibly every 2 to 3 weeks, depending on the patient. We have tissue expanders other than breast, 11960 to 11971. And the tissue expander is something, looks like a sack. They go in and they fill it with either fluid or air, and it kind of blows up like a balloon. And what it does is it expands or stretches out the skin so that they can go in and put a permanent implant in once the area is at its designated size. Expanders can also be used to repair scars and removing tattoos by stretching the skin. These codes are divided according to whether the service is an insertion removal or an expander removal with replacement of a prosthesis. So, and again, this particular 11960, it says other than breast. And if you look underneath it, it tells you for breast reconstruction with tissue expanders, use 19357. So even though you'd be looking it up alphabetically if you were doing a breast one, it should lead you to the 193 code. But if it led you to this expansion code and you were specifically looking for the breast, hopefully you see that wording that says other than breast and then read underneath it to see where you would go. On page 395, implantable contraceptive capsules will be in this section as well. These are inserted under your skin by a small incision in the upper arm. The capsule stays there for a number of years and then it has to be removed. Read the descriptions in the implantable contraceptive capsule codes 11976 to 11981 carefully, because there are codes for insertion and removal. So again, we need to know whether they're putting it in, whether they're taking it out. In addition to reporting the implantable contraceptive capsule, if you supply the Norplant, for example, is one of them. If your office bought the Norplant and you're supplying it, not only would you bill one of the codes from this section, but you would also bill the supply code, which would be a J code out of your HCPCS book. But again, the only way you can bill for the Norplant or the medication is if your facility purchased it, then you can bill for it. Subcutaneous hormone pellet implant. This is insertion of a hormone time released into the buttocks for people for treatment of menopause. 11980. The pellet does not need to be removed, but a new pellet needs to be inserted every 6 to 9 months. So it's absorbed into the bloodstream, but in order for it to continue to work, you need to keep replacing it. So that means a new one in there. So look at exercise 14.1 and just take a look at number 2. Removal of 15 skin tags. Where would you start with that one if you were looking it up alphabetically?
Skin.
Skin. Try skin. I'm going to look under removal.
Probably that.
But remember what I said before. Sometimes we're going to find things under several different roots. So it could very well be it is under skin as well. So don't change that. You want to look it up that way. Let me know where it leads you when you get there.
It says tags, removals, 11200 and 11201.
Okay, 11200 and 11201. So let's go see which one fits. Should be on page 74.
I think if you have the 2018, yours is off a little bit because it's 78 in the 2018 one.
Okay, yep, I have the 17 version, so I need to get my new book.
Okay, so it says removal.
Removal of 15 skin tags.
So it would be 11200 and then 11201 times. Oh wait, no. Just the first one. That's
Very
up to
good.
50.
You caught yourself. Good. 11200 because it's removal of skin tags, any area up to and including 15. The add-on code is for each additional 10 or part thereof. So if we did 17, then you could use both codes. But yes, correct. 11200. Okay. On the repair section, which is going to start with codes 12001, you'll see there are some notes preceding those codes in your CPT book. When we code wound repair, we have to keep in mind the length of the wound, and this would be in centimeters, the complexity of the repair, and the site that is being repaired. So length, complexity, and site. There are a lot of different types of wounds. Wound repair is classified by the type necessary to repair the wound. We have 3 means to do that. We have what's called simple wound repair, which is 12001 to 12021. Simple would include your epidermis, dermis, and subcutaneous tissue, and it requires only a single layer closure. So hopefully your doctor is going to be documenting this in the notes. You will see that the charge for the closure in this instance would be included in the evaluation and management code. We would not report it separately with a repair code. The repair codes are for suture closure. On page 397, intermediate repair is closure of 1 or more layers, subcutaneous tissue, superficial, which is non-muscle fascia, in addition to the skin closure. in this case, we would report 12031 to 12057, which is intermediate closure. And then you have complex, which is a complicated wound closure involving revision, debridement, extensive undermining, stents, or retention sutures, as well as more than just a layered closure. 13100 to 13160. And again, if you look at the notes prior to those codes, it does give you the definition of a simple, intermediate, and complex repair. It also gives you little tidbits about when you are coding multiple, or when multiple wounds are repaired. It tells you to add up the lengths in the same classification from the same anatomic site. So again, good little tidbits in those guidelines, so to speak, before. So if you look at the pictures on the previous page, you'll see A and B are laceration type wound, C and D would be puncture wounds, E and F would be what's called an abrasion, and G and H are an avulsion, and I would be an incision. And then you can see the different layers of the skin. So when we're talking about that intermediate going down into the non-muscle fascia, how far down that would be going. On 397, the coding shot there about HCPCS code G0168. This reports skin closure using adhesives such as Dermabond, which is like super glue, people call it. It's put into the wound. They hold the edges together. They put a bandage over it, and it seals it instead of using stitches. Most third-party payers use the simple repair code to report skin closures using adhesives. Medicare requires this code. So this is where we need to know the rules of the insurance carrier. Because if all of our regular health insurance wants the code out of your CPT book, but Medicare wants their particular code, that's something we have to make sure we remember. Because if we were to bill Medicare the code out of your CPT book, it would be denied, and you would have to correct the claim and then send it back in. So here is what was in the guidelines, but for each anatomic site, the length of the wounds are totaled together by complexity. So simple, intermediate, and complex. All simple wounds of the same site are reported together. All intermediate wounds of the same site are reported together. And all complex wounds of the same site are reported together. Codes group together sites that require similar techniques to repair. So that code 12001, superficial scalp, neck, axilla, external genitalia, trunk, and extremities, and that does include the hand and the feet. When there is more than one type of repair, the most complex repair would be listed first, and then the secondary procedure would be used with modifier 59. So again, we need to rely on our physicians, obviously, to tell us which one is more complex or severe. But in this case, we know that if it's a complex closure or repair, that is obviously more severe than a simple closure. So that helps us out a little bit. We don't have to rely on getting that information from the physician with regards to this type of reporting, whereas we may in other instances. So the CPT manual notes located under the repair closure have extensive definitions, which I just talked about each level of repair. And again, it gives you the notes about adding up the sites. So that is real good information to make sure you're reading those notes as well. 3 things to consider in components of wound repair. Simple ligation, which is tying of vessels. That is considered part of wound repair. We would not be able to report that separately. But if it's a simple ligation of medium or major arteries, we can bill that separately. Simple exploration of surrounding tissue, nerves, vessels, and tendons, that's part of the repair process. So in other words, for a gunshot wound, for example, if they're down there poking and prodding, trying to make sure there's no little pieces of shrapnel or whatever, that's part of the process. We're not going to be able to bill for that digging as a separate code. Normal debridement, cleaning, and removing skin or tissue from the wound until healthy tissue is exposed, we cannot bill for separately as well. If the wound is grossly contaminated and requires extensive debridement, then we may be able to use a code from the debridement section 11000 to 11047. The next section is tissue transfers, grafts, and flaps. So this goes over roughly to codes 1400. There are a lot of grafting procedures for correcting defects, skin substitutions. So to help us understand skin grafting, we need to know the recipient site is the area of the defect that is receiving the graft, and the donor site is the area where the healthy skin or graft was taken from. So if you look down below, we're going to go over just a few different types. We have adjacent tissue transfer or rearrangement. And here, if you look at the codes, there are a lot of different types. 14,000 to 14,350 are different codes for these adjacent tissue transfers. And it does show you in your CPT book a couple of diagrams giving you some different scenarios as well. One of the more common ones, the diagram is on 399. It's what we call a Z-plasty. There's a W-plasty, there's a VY-plasty, there's rotation flaps, there's advancement flaps. So all of these procedures move a segment of skin from one area to an adjacent area while leaving at least one side of the flap intact to retain some measure of blood supply to the graft. Incisions are made, skin is undermined and moved over to cover the defective area, leaving the base intact. And then the flap would be sutured into place. Your adjacent tissue transfers are reported according to size of the recipient site. It is measured in square centimeters. And again, here's where you may need to do some converting. 1 inch equals 2.54 centimeters. Simple repair of the donor site would be included in the tissue transfer code. We would not report that separately. However, if there is a complex closure or grafting of the donor site, because it is complex, we can report that separately. These codes 14,000 to 14,350 are divided based on the location of the defect. And again, if you look in your CPT book, you will see it says trunk, and then 14,020 is scalp, arms, and or legs. 1440, forehead, cheeks, chin, mouth. So again, knowing the location is going to be a key to helping us get the correct codes. Any excision of a lesion that is repaired by adjacent tissue transfer is included in the tissue transfer code. These codes can be found in your CPT manual under the main term skin and then adjacent tissue transfer. So again, here's the playing with the words. You may try to go directly to adjacent tissue transfer and you wouldn't find anything. So then you may have to go, okay, what are we working on? Oh, we're doing it on the skin. Let's try that. So you can see up on top of 399, again, there's a debridement of the tissue, and then the Z-plasty, and then a sacral ulcer where they take the tissue and they're doing a rotation flap. So they're actually trying to use the skin and cover it in a circular motion so that it kind of blends and it's not something that is out of the norm. Skin replacement surgery, and again, if you look in your CPT book, look at the notes. There's plenty of notes there about skin replacement surgery. It gives us definitions. It talks about the different types of grafts. So these codes 15002 to 15278 report surgical preparation, and the preparation codes, if you look at your books, is 15002 to 15261. Uses a variety of grafting materials and repair methods using skin or skin substitutes. The site of the defect may require surgical prep before repair and would be reported with a code from 15002 to 15005 based on the size and site. Free skin grafts, 15100, 15101, and then 15120 and 15121 are pieces of skin that are either split thickness, which is epidermis and part of the dermis, or full thickness, which is both. As when we flip the page, you'll see a picture of it. These grafts are completely free from the donor site, placed over the recipient site. There is no connection left between the graft and the donor site. These skin grafts are reported by recipient site, size of the defect, and type of repair. And again, measured in square centimeters. Many of your code definitions in this section refer to measurement in square centimeters and percentage of body area. And when they're talking about the square centimeters, it's applied to adults and children adults and children over 10, and the percentage would be only if you were dealing with a person who would be under the age of 10. So if you look on 400, there's your split thickness and your full thickness graph. And then figure 1423, you can see the opening on the burn on the first web space. And then after they use a dorsal metacarpal artery flap, that's what it looks like after it was repaired. It's pretty impressive to see some of this done. On 400, a pinch graft, which is code 15050, is a small split thickness repair. Often this type of graft is referred to the patient record as a STSG. So that's a split thickness skin graft, or a FTSG, full thickness skin graft. Autografts are taken from your patient's own body, whereas allografts are grafts taken from another human donor. So again, we have epidural autografts, 15110 to 15116. We have dermal autografts, 15130 to 15136. And if you look at these codes in your CPT book, you'll see that these are based on depth, location, and size. There's tissue cultured autografts, 15150 to 15157. These are cultured from your own skin cells. So therefore, hopefully, you have a less chance of rejecting it than if it comes from somebody else. Acellular dermal replacement, 15271 to 15278. Skin replacement products based on location and size. Temporary allografts, 15271 to 15278. Again, location and size. And the temporary ones are used just to cover the area while the injury is healing, and then they would take the temporary one off. If it doesn't fully heal, then it may need a permanent graft, and that can be placed over that site at a later date. It does not need to be done immediately. You can see there on the bottom of this page, they're doing a meshed autograft. Up at the top of 401, we have a couple of different ones. There's the cultured epithelial autograft, and that 1426 is that same area as 1425, 1 month after it had been grafted. So sometimes these things are quite the lengthy process and may need more than one grafting. So if you are coding this type of thing, it may be something that's done on a regular basis over a long period of time in order to get it to heal. Allograft, tissue cultured allogenic skin substitutes, 15040 to 15261. They are obtained from a donor who is genetically different but of the same species. Xenografts are grafts taken from a different species, also called heterografts. So this would be like a pig skin, for example. Skin substitute grafts are reported based on wound surface area. So areas up to 100 square centimeters of the trunk, arms, or legs would be 15271 for the first 25 square centimeters, and then 15272 for each additional. So here's where I said sometimes you're going to have to do some multiplication out to see how many square centimeters we're actually dealing with. Again, flaps, a physician can develop a donor site at a location far away from a recipient site. This graft may need to be done in stages. It may not be able to be done just in one setting. The graft code can be assigned more than once when it is done in stages. Report the donor site when a tube graft is formed for later use, or when a delayed flap is formed before it is transferred. The recipient site would be reported when the graft is finally attached. In a delayed graft, the portion of the skin is lifted, separated from the tissue, but it stays connected to the blood vessels. That way the skin stays viable while it's being moved from area to area. There are two categories of codes for flaps. The first one starts with codes 15570 to 15738, and these are divided based on type of flap, and you'll see in your CPT book it's skin and or deep tissues, and then by location of the flap. So where was it? The trunk, the head, the lips, whatever it happens to be. The second category, 15740 to 15777, is divided based on the type of flap: free muscle, free skin, facial, or hair transplant. If you look on page 402, a couple of different scenarios. The first one is somebody who had a mastectomy, and what they are doing is they are using a tube flap to create something that is similar to the breast. So they've used the excess skin down in the belly area, shaped it like a tube, and then in stages that is removed or taken up and put into the breast area and then formed into the breast. This type of reconstruction usually can take up to a year to complete, and then may even need more surgeries after that. And then in the figure 1428, you can see she's got a big open area on her nose, and they are taking some excess skin down by the crease of the lip there and cutting that off and moving it up. And they do a pretty good job, because if you didn't know, you would just think that was one great big long incision down to her chin. So it's pretty impressive to see how they do that. Within the flap codes, 15740 to 15750. The flap, donor site, and recipient site remain connected for a period of time. This can be an island pedicle or neurovascular pedicle. The pedicle at the end of the flap remains connected to the donor area. An island pedicle flap has an artery and a vein. Neurovascular flap contains an artery, vein, and nerve. So if it's just an island, it's an artery and vein. Neurovascular, it also has nerves. The connection between the donor and recipient site remain in place until the graft has healed, and then they will sever that connection. On page 403, some other procedures with regards to repair. 15780 to 15879. These are abrasion, chemical peels, blepharoplasty, which is surgery on the eyelid. Dermabrasion is used to treat acne, wrinkles, or keratosis, which are little horny growths. These codes start with 15780 to 15781. These are for the facial dermabrasion, and it's based on the surface area treated. Areas other than the face for dermabrasion would be reported with 15782. Tattoo can be removed with dermabrasion. They use a high-speed mechanical wheel. This service 15783. Abrasion codes 15786, 15787 is abrasion to remove a lesion, scar, tissue, wart, or callus. Can also be used to remove sun-damaged skin. The first abraded lesion would be 15786, and then each additional 4 or fewer 15787. And again, you can see how that is worded in your CPT book as well. It's got the plus symbol next to it, and it tells you to list separately in addition to primary procedure. Chemical peels. Chemical is applied to the skin and then removed. The skin surface sheds its outer layer, just like when you get burned by the sun. This is used for cosmetic purposes, so to smooth your wrinkles out around your mouth, remove liver spots. These codes 15788 to 15793 are divided on whether the peel is on the face or not on the face, and the depth. So if it's epidural or dermal, Because it says this is used for cosmetic purposes, if you are working in, for example, a dermatology office or an office that does a lot of cosmetic stuff, please check insurances for a lot of these procedures. A lot of cosmetic stuff is not covered, which means you have to get an ABN signed if you want to be able to bill your patient. Cervicoplasty, 15819. Physician removes excess skin from the neck. Again, this is usually cosmetic. Blepharoplasty, 15820 to 15823. Again, typically cosmetic, removing excess skin and supporting the muscles of your upper eyelid. Rhytidectomy, removal of wrinkles by pulling the skin tight and removing the excess. 15824 to 15829. And again, you can see some lovely pictures on the bottom. That can also typically be done for cosmetic purposes. Excision of excess skin and subcutaneous tissue of other parts of the body, so your stomach, buttocks, arms. These may commonly be done during bariatric surgery. These are reported with codes 15830 to 15839. For abdominoplasty with paniculectomy, which is that extra skin hanging in your abdomen area, 15830 with an add-on code of 15847. So that 15847 is excision of excessive skin of the abdomen. So you're allowed to code that in addition to your primary procedure. Graphs for facial nerve paralysis, 15840 to 15845. They harvest a graft from a location on the body and then they put it over the damaged area of the paralysis. There are codes for removal of sutures and or dressing changes under anesthesia, 15850, 15852. Sometimes, depending on sutures and staples and dressing changes, depending on how many or location and your patient, some can be removed obviously without the patient requiring anesthesia, and other times they're going to require anesthesia, and your codes will say sometimes specifically with anesthesia. Lipectomy or liposuction, 15876 to 15879, and these are based on body area being treated. So again, head, trunk, upper, lower extremities. If this is done bilaterally, so you're having both arms or both legs done, you have to use your modifier 50. You will note that the code does not specifically specify side. We have a small section on pressure ulcers. Pressure ulcers are decubitus ulcers or bed sores, another more common word for them. They usually appear where you have bony projections, such as your hips, tailbone. Pressure on the areas decrease blood flow, and you get a sore. So with continued pressure, the sore gets ulcerated, and deeper layers of the tissue, the fascia, the muscle, and the bone can be affected. Your depth of the ulcer will be referred to in stages, and you can see these stages on the top of page 405. So stage 1 affects just the epidermis, that top layer. Stage 2 goes down into the subcutaneous fat. Stage 3 is going down almost into the start of the muscle. And then stage 4 is going down into the muscle and hitting on the bone. So sometimes with a stage 4 ulcer, you can actually see the bone being exposed. Although a pressure ulcer can be seen, the depth sometimes cannot be seen. So the treatment for a pressure ulcer, 15920 to 15999, is excision of the ulcerated area to the depth of the uninfected tissue, fascia, or muscle. So for example, if it's a stage 3, they're going to go and remove everything down through that muscle layer, almost to the bone. You will note many different pressure ulcers also have the words with osteectomy under them. Osteectomy is removal of the bone that underlies the ulcer area. So again, read code descriptions carefully with ulcers to see whether or not we are removing part of the bone as well. The next section in your CPT book is burns. And if you flip the page, you can see what we call the rule of nines, which is helps to calculate the percentage of body area in adults. The kids uses something called Lund router to get the percentage, because the children are different sizes than adults, obviously. So if you look on 406, you will see for an adult, we have, when we're talking about burns, we have the head, we have 4.5% would be the front, 4.5% would be the back. For your upper torso, that would be 9.5% for the, or 9% for the front, 9% for the upper torso and the back. And then you can see how it's broken down. You can see for a child how different that is, and it's based on age. So until they get to the age of 15, they would not qualify to go by the rule of nines for a child. So you can see how the percentages are different. And obviously the infant's head is not as big as an adult head, so it's based on half of the head, half of the thigh, and half of the lower leg. So again, we as coders are not required to calculate the percentage of the body that is burned. The physician does this in the medical record. We just need to know to look for it to include it in our code. Burns are classified as first, second, or third degree based on depth of the burn and documentation. So epidermis would be a first degree burn, chemical burn would be a second degree burn, and a subcutaneous would be a third degree. And if you look at figure 1436, you can see again, your first degree is just the epidermis, second and third. And I will tell you, depending on what is burning and what adheres to your skin, sometimes it goes real quick and you can end up with a third degree burn before you even know it. And the example I like to use is my children, they love to sit outside and we have fires outside. And a couple years ago, before he got into the service, he was old enough to know better, but he threw a piece of plastic on the fire. Well, that piece of plastic, of course, blew off and landed on his shin because he had shorts on. By the time he felt it hit his shin and could reach down and pull it off, it had already gone down through and we could see his shin bone. So he already got third degree burns for as quick as that took. So again, depending on the depth. These codes, the burn dressing and or debridement codes, are based on whether the dressing or debridement is small, medium, or large. These codes are 16020 to 16030. Small would be less than 5% of the body. Medium would be the whole face, a whole extremity, or 5 to 10% of the body. And large would be more than one extremity or greater than 10%. And again, in your CPT book, they do have a grid as well for the child. But again, if it helps to put, a small area, 5%, or any of that wording that's in your textbook, in your CPT book, that is absolutely fine. You can write, again, anything you want in there, just no sticky notes. Bundled into 16,000 and 16,036 is the application of a dressing, such as temporary skin replacement. So I would go to that code 16000, and next to it I would write includes dressing. And that way I knew I could not bill for it separately. If this was something I was doing day in and day out, obviously I would know, but for the purpose of the exam, I may not remember because it's not something I do all the time. Some third-party payers bundle materials such as BioBrand into the burn or treatment codes, and the BioBrand is like a silicone film with a nylon fabric embedded into the film. Collagen is then embedded into that film and fabric, so it helps cover during the healing process. So again, knowing whether or not we are able to bill that with our carriers. The burn categories contain codes for escharotomy, 16035 to 16036. This is where the procedure actually cuts the dead skin away that covers a full thickness burn. So when you get a burn, that crusty stuff covers the area that you want to try to heal, and when it covers it, it is slowing down that healing process and diminishing the flow of blood. So again, you can see some third-party payers allow you to submit charges for burn care using the first date of service to the last date of service. Other payers require you to list each date of service and each service separately. So again, it's going to depend on your payers for that. So if you look down at exercise 14.2, look at number 2. After an assault with a knife, a patient requires simple repair of a 3-centimeter laceration of the neck, a simple repair of a 4-centimeter laceration on the back, simple repair 5-centimeter laceration on the forearm, and a complex repair of a 3-centimeter laceration on the abdomen. And then it tells you, remember to use modifier 59 with the least extensive repair. So first of all, which one do you think is going to be coded first?
The 5-centimeter forearm, because it's bigger area.
But it's a simple repair, isn't it? So do you think we code the complex repair first?
Yeah.
Okay, so let's go see, where would you look for this? If in your alphabetical index, where would you go?
Laceration.
Laceration? Okay. Let's see, laceration. Laceration repair says see repair laceration. All right. So repair laceration.
Stomach.
Okay, let's go look at that code, 43501. We haven't even talked about that code yet, though, have we?
No, so that can't be right, but
So let's go 435, what was it? Oh. Four three five oh one. Whoops. States gastrotomy with suture repair of bleeding ulcer.
no.
So that's not in. That's not it. What section are we in? Are we in the skin section? So how about if we go to repair of the skin
Okay.
instead of laceration? Let's try that.
One 13100 to 13160.
Okay, for complex 13100 to 13160. So let's go take a peek at that. And it's of the abdomen, which is also considered the trunk. And it's 3 centimeters. So
13101.
13101 would be for the complex repair of the 3 centimeter laceration of the abdomen. So what I would do here is, knowing you can look right to your left and see the repair for simple instead of going back to the back and looking it up.
Mm-hmm.
We've got a 3 centimeter neck, 4 centimeter back, and 5 centimeter forearm. So one of the things we need to do is see if the neck, the back, and the forearm are all considered the same body area. So if you look at that 12001 code, it says scalp, neck, okay, we got the neck, axilla, genitalia, trunk, which would be the back, and forearm, which would be extremities. So that fits all three of those, right? Now let's add it up. 3 and 4 is 7 and 5 is 12. So which CPT code would we be able to pick for the simple repair of all three of those areas?
12004.
12004. Correct. And again, we were able to add them all up because they're all simple and they actually ended up being all in the same body area. And as they put the special reminder there, that second one, the 12004, would have your modifier 59 attached to it. Correct. And what the insurance company will do at that point is when they get it, they're going to pay you obviously for the first one, and they're going to see that the simple closures were something completely different, and then they will reimburse appropriately. So does that make sense? If it's the same area, same type of closure, you can combine them. Okay. Look on page 408 and take a look at number 5. The patient had a 20 centimeter, I guess that's squared, I don't know, 20 cm to the 2 defect on the right cheek, and it was repaired with a rotation flap or an adjacent tissue transfer. So where would we go to look for that? Do you remember we started with the skin and then adjacent tissue transfer? I'm going to go to adjacent just for grins and giggles and see if they list anything under adjacent in the back. But they do not. So let's try skin instead. So skin and then adjacent tissue transfer. I'm roughly on page 991 alphabetically, so yours is going to be pretty close to that.
Okay, so skin, so defective.
So this is a cheek. Oh, I get it. 20 square centimeters.
Okay, so defective.
041. Would you use 14041?
14041 is absolutely correct because it's on the cheek and it's 20 square centimeters. So we would not use the one that's pertinent to the trunk or the scalp, arms, and or legs. Correct. 14041. Good. Okay, the next section in your CPT book is destruction. These codes are destruction of lesions by means other than excision. Codes 17,000 to 17,286 are for benign, premalignant, or malignant lesions by electrocautery, electrical current, cryo, which is cold, laser, chemicals. Read the notes under the destruction category. Again, there's not many notes there, but it tells you what any method consists of. So if it says, the description says any method, that's cryo, electro, laser, and chemical. Can be any one of those. 17,000 to 17,004 is destruction of lesions by the number treated. So if they go and have 20 lesions removed using cryo, it would be 17,004 because that's 15 or more lesions. If they had 6 lesions, the first one would be 17,000, and lesions 2 through 6 would be reported with 17003. Now note on that 17003, it does say 2nd through 14, but then there's the word each, which means we now have to say that 17,000 was for the first lesion. We removed 5 more. So it would be 17,003 times 5, because it does specify each. That's tricky because it does say 2nd through 14. So a lot of people just look quick and figure that means any number of them. But after that it says each. So it is telling you you have to specify the number. On the bottom of 408, there is something called Mohs micrographic surgery, 17311 to 17315. It's named after Frederick Mohs, a doctor. They use a microscope during the surgical procedure to view the lesion, assess the invasion, and by doing that, your surgeon acts as both the surgeon and pathologist. Sometimes there might be a separate person acting as the pathologist. But what they do is under the microscope, if you look on page 409, they can go in and if they take down to that first red dotted line and they look at it under the microscope and still see the bad cells, they know they haven't gone far enough. So then they can go in and cut out a little bit more. Look at that under the microscope. If they don't see any of the bad cells, great, they got it all. If they see the bad cells, they know they need to go deeper. This way, the patient is there. You've not taken a piece and sewn them up and sent them on their way to find 4 days later that the pathology is positive and you didn't remove it all, and now you have to have them come back. So this is a means of trying to get it all while they are having that one surgery. So you can again see the codes under this section, 17311 to 17315. So again, the procedure involves mapping the tumor and removing tissue down to the level where the cancerous cells can no longer be seen. The codes in this category include removal of the lesion and pathologic evaluation of the lesion. The codes are based on the stage, so first or second of the surgery and the number of tissue blocks. So again, it gives an example of a patient going to the dermatologist with a lesion. They do a biopsy using a microscope. They determine it's basal cell carcinoma. They want the patient to have the lesion removed the same day using this Mohs technique. So now the dermatologist is going to go in and they're going to continue to take pieces until they no longer see that basal cell carcinoma. On page 410, so look at number 3, Mohs micrographic surgery by a single physician removing and examining 3 specimens, first stage of the neck. So if you were going to go out back and look it up alphabetically, would you go to Mohs? Probably. Yes, you would. So in this case, we're right here, so go ahead. It's single physician, 3 specimens, first stage of the neck. Which code would it be?
One 17311.
17311. That's head, neck, hands, feet, genitalia, or any location involving muscle, cartilage, bone, and tendon. First stage up to 5 tissue blocks. Correct. So some of them looking up are a lot easier than others. But again, just remember, practice, practice, practice. We're now going to go on to
those 3 circles.
What was that?
Why does it have those 3 circles in front of it?
The 3 circles is just to let you know that sometimes you may have more than one code.
Okay.
You'll see it some places and other places you won't see it. In this case, we don't have an additional code because we didn't have more than 5 tissue blocks, so we're not going to have that add-on code. I think sometimes they like to throw that in there to try to mess you up because a lot of times they're going to give you 2 spaces anyways. So, but yes, that is what that means. So now on to the breast procedures, 19,000 to 19,499. These are based on what did we do. So did we incise, excise, introduce, repair, or reconstruct? Again, read the documentation to identify the procedure. In an incisional biopsy, the incision is made into the lesion and a portion of the lesion is taken out. In an excisional biopsy, the entire lesion is removed. So incisional biopsy, they take just a piece. Excisional biopsy, they take the whole thing. Sometimes these codes, the percutaneous breast biopsies, 19081 to 19086. You will see that there are also codes if they should put a location device, so a clip, a pellet, a piece of wire, a needle, a radioactive seed. If they put that in the breast area without a biopsy, 19281 to 19288. And a lot of times they will do this when you have an abnormal mammogram and they find a area, they will put some sort of marker in there so that when you get in for the surgery, they know what area it is in. There are many mastectomy codes. So again, reviewing the operative report to confirm whether they take muscles, pectoralis muscles, axillary lymph nodes, internal mammary lymph nodes. That's all going to make a difference on the code that we can select. If you look at the codes under the mastectomy section, partial mastectomy, 19301. This is where a portion of the breast tissue is removed. If they do axillary lymphadenectomy as well, it would be 19302. So if you look at those codes in your CPT book, you will see the 19301 says mastectomy partial. That's all it says. 19302 would be mastectomy partial with axillary lymphadenectomy. If you look at the pictures on top of 411, you will see the different types of mastectomy: simple, modified radical, radical, and partial. So we just talked about the partial, so only a portion of the breast tissue. A simple or complete, 19303, is one where all the subcutaneous tissue and breast tissue is removed, and the nipple and the skin may or may not be removed. A subcutaneous mastectomy, 19304, is where the skin and muscle is left, but all breast tissue removed. The modified radical, 19307, is where the breast is removed in addition to the axillary lymph nodes, and the pectoralis minor muscle may or may not be removed. The major pectoralis muscle is not removed. Your radical, 19305, entire breast is removed in addition to the pectoralis muscles and axillary lymph nodes. So with the radical, they are going to remove both the pectoralis major and the pectoralis minor. Breast lesion is often identified in a screening mammogram. They would then do a breast biopsy. During that biopsy, they send the specimen in. If it comes back positive, they would go in and you meet with a surgeon and you go over your options depending on the size and what it is. Sometimes just that mass can be removed. Other times, if it has spread into the lymph nodes, that is, or the ducts, that is when the mastectomies need to be done. The repair and or reconstruction codes 19316 to 19396 include codes to report breast reduction 19318, augmentation or enlargement 19324 and 19325, and breast reconstruction 19357 to 19369. The reconstruction in the 19357 includes that tissue expander placement, which allows for subsequent expansion. Again, that tissue expander stretches the skin that overlies the breast tissue or the breast so that they can go in and put the permanent implant in later. I will tell you that you don't think you're really going to feel that skin tissue stretch until they actually put liquid in that tissue expander. You can really feel it stretch your skin, which is the weirdest sensation I have ever had. Very bizarre, just like little twinges, but you can just feel that skin stretching. So again, we've got the reconstruction as well as the mastectomies. If you look on 412, any breast procedure done on both breasts needs to be reported as a bilateral procedure. So look down at number 3, right modified radical mastectomy, including axillary lymph nodes without muscles. Right modified radical mastectomy, including axillary lymph nodes. So where would you go for that one?
Probably breast, because that's what we're talking about, or mastectomy.
Right, and I think this is one that you would be able to find either way if you went to the back under either one of those. Right modified radical mastectomy, including axillary lymph nodes, but no muscles.
One 19307.
19307, correct. Now, you're going to put anything on that? Which breast did we do it on?
RT.
RT for right, correct. 19307 RT. Mastectomy, modified radical, including axillary lymph nodes, with or without pectoralis, but excluding pectoralis major. Yep, very good. 19307. Good.
Now, do we not do the one that says with axillary, the 19302, because this says including? Is including and with not the same?
No, because the 19302, if you look back at the base code, that is just a partial mastectomy.
Oh, okay.
So we were looking specifically for a modified radical.
Okay.
Yeah. Okay, so congratulations. We've gone through the entire integumentary system. Any questions on the skin system? Nope. All right, you ready to move on to musculoskeletal? Does anybody need a break before we start on this? All set? Okay. All right, so musculoskeletal, 416 in your textbook. This is, and you will see a lot of the chapters are formatted the same way. This is formatted by anatomic site, and then what did we do? So incision, excision, introduction, removal, repair, fracture, dislocation, arthrodesis, amputation. So most of the codes in the musculoskeletal system are used extensively by orthopedic surgeons, but there are some codes in this section that can be used by primary care, family practitioners, ER physicians if they're getting the patient first because the orthopedic office is closed. Also, especially if they are splinting or casting, anything like that. So review of the medical record will help you identify key information necessary for coding. Identify whether the procedure is being performed on soft tissue or bone. So that is one of the keys in the musculoskeletal system. Subcutaneous soft tissue tumors, fascial or subfascial soft tissue tumors, which are within or below deep fascia, but it doesn't include the bone. Radical resection of soft tissue tumors, subcutaneous or subfascial, but with wide margins. Radical resection of bone tumors, wide margins, vessel exploration, and or repair reconstruction. So careful reading of musculoskeletal guidelines is a must before reporting excision of tumors. We then have to determine whether treatment is for a traumatic injury, acute, or a medical condition, which is chronic. Identify the most specific anatomic site. So when we're talking about the spine, we do need to know whether it's lumbar, cervical, or thoracic. Our codes are not going to be generic. They need to hopefully be as specific as we can get. Determine whether code description includes grafting and or fixation. If grafting and the fixation is not in the code that you find, then it is possible that we can code the grafting and the pins or screws in addition. Read the entire code carefully to determine whether it describes a procedure that was on a single site. So each finger, because if it's done on a single site and we do 3 fingers, we need to do it 3 times to get paid appropriately. Check any medical terms you do not understand in the dictionary, or if you were using this book or had this as a reference in your office, there is the glossary in the back. So the first part we're going to talk about is fractures. Fractures are coded by treatment. Are they open, closed, or percutaneous? An open treatment of a fracture is made when surgery is performed on a fracture which is exposed by an incision made over the fracture and the fractured bone is visualized. Closed treatment is done when the physician repairs the fracture without directly viewing it. So that means that you have a fracture of your forearm and they do a manipulation of your arm to try to get the bones to line back up. That's a closed procedure. They are not physically looking at the bone through your skin to make sure it lines up. The treatment method, open or closed, depends on the type and severity of the fracture. Closed fracture can receive either closed, open, or percutaneous fixation, whereas a more complicated compound fracture usually needs an open treatment because they have to put the wires, the pins, or the screws in. Fractures are coded to specific anatomic site, and then as to whether or not they used manipulation. All fractures and dislocations are reported based on the reason for the treatment. So for example, a hip replacement, arthroplasty, is done for osteoarthritis. That would be code 27130. So some of these codes will give us specifics as to why or the reason it's being done as well. With ICD-10, now we need to know what type of fracture it is. So if you look at the pictures on the bottom of 417, we have a green stick fracture and a avulsion fracture, so that means it chipped the bone. Comminuted, simple, spiral fracture, impacted, transverse, oblique, Colles fracture, and a compound fracture. So if our doctor doesn't specify what type of fracture it is, if they do not give us I like to call it a generic code, we're going to need to inquire because we may not be able to select an appropriate code unless we know what type of fracture it is. On page 418, that hip replacement that I talked about, that code 27130, if the hip replacement was done for a fracture, that changes the CPT code you would use. The code now would be 27236. So again, sometimes the code is going to be for a specific reason, and we're going to need to know whether it's a medical condition or a fracture, for example. CPT manual defines closed, open, and percutaneous as below. So your closed treatment, again, you treat fractures by one of the three methods. You can do closed without manipulation, closed with manipulation, and closed with or without traction. This truly depends on the type of fracture, the patient, and what the fracture looks like. Sometimes when you break a bone, as you noticed on the previous page, if it is a simple fracture, meaning it's not out of line, just split, you may be able to do absolutely nothing to it, but put it in a cast. So that would be a closed fracture without manipulation. But let's say it shifted a little bit. So now the only way we're going to be able to fix it, or try, is by doing manipulation. So they try to move it to get it in line. That would be closed with manipulation. And then there's the closed treatment with or without traction, meaning that they'll manipulate it and they might take a quick x-ray to make sure they've lined it up properly, and then they're going to put a pin or a screw in to hold it in place while it heals. So again, it depends on the type of fracture. It can depend on the age of the patient. Some elderly patients may not be able to undergo surgery because of other medical conditions. This may be the only type of treatment available at that time for their particular fracture. Manipulation is attempted reduction, so that means they are going to try their best to put that bone back in proper alignment. They can bend it, rotate it, pull it, or guide it back into place. I will tell you, it takes a strong person for that manipulation to be done without some sort of anesthesia, because my son will tell you it hurts like the dickens. But if they can try to get away with doing it that way, they definitely will. Closed treatment without manipulation. So again, they're going to immobilize it with a splint, cast, maybe just a like shoulder sling or a finger splint, something like that. The initial casting or splinting is included in the fracture care. So if we bill a fracture care for a distal radial fracture and it's all lined up, it's a simple fracture, we don't have to do anything to it, but we're putting a cast on it, we cannot bill that cast in addition to the fracture code. We're going to bill the fracture code, and that first cast is already included in that because they treat that fracture code as a surgical code, so they allow more money for it. So the initial cast is not included. But let's say in 2 weeks, that patient comes back, we take the cast off, and we re-x-ray them. Still not healed, so we've got to put another cast on. We can now bill for that second cast. You just cannot bill for the initial cast. You can bill for initial splinting or casting material, above and beyond what is normally used. So if it took 5 rolls of casting material on somebody's leg because they were a really large person, we would be able to bill that extra material because it's above and beyond. If the cast needs to be removed and reapplied during that global period for that fracture code, we can report the additional cast application or splint with a code from 29000 to 29799, which are the codes for the cast, depending on whether it's an arm or a leg or a finger or whatever it happens to be, with a modifier 58 saying it is staged and or related. That way we will get paid for that second or third or fourth cast. Only charge for the cast removal without reapplication if your physician is not assuming care for the fracture. So let's say somebody else took care of the fracture and now the kid is, he hurt it while he's home, now he's back up here in school, and all you're going to do is take off the cast. You can bill for that cast removal. Closed treatment with manipulation. So this means the physician has to reduce it or move it to put it back in place. 21320 is closed treatment of a nasal bone fracture. And that is an example of a nasal fracture down at the bottom of this page. Open treatment is when the fracture is open or exposed to the outside, and they will open it to view and put internal fixation such as pins, screws, wires, whatever it happens to be. So 23630, if you want to see how that is worded, is an open treatment of a greater humeral tuberosity fracture, includes internal fixation when performed. So it doesn't have to have internal fixation, but if it does, it includes it. Excuse me. Fractures are divided based on whether the fracture is pathological, which means it occurred in an area of weakness, or traumatic due to an injury. Be careful when you are looking up codes in your workbook for fractures. If it says it was a fracture because the woman fell and she has osteoporosis, for example, that is a pathological fracture. She has a bone weakness. If it is a traumatic fracture or an injury, that would be a traumatic fracture. But there is a difference between pathological and traumatic. We also need to know with fractures there will be a 7th character to indicate whether this is the initial or subsequent visit, whether it is open or closed. And again, open means it's broken through the bone cortex and the bone is exposed to air. Closed means it did not expose to air. We will have a 7th digit for healing. Was the healing routine or was it delayed? And then there's also a 7th digit for a non-union. Again, when ICD-10 came out, I had to take a copy of those 7th digits saying non-union, malunion, first visit, second visit, what subsequent visit. And I had to bring that to my provider and say, in order for me now to code the fractures, this is what I need you to document. So anything that's going to help them so that we can get the right codes. Percutaneous skeletal fixation is a fracture treatment neither open nor closed. The fracture is not open to view, but the pins or the screws are placed across the fracture site, sometimes using X-ray. They can do this of the toe, the fingers, the wrist, If they do it of the phalanges with manipulation, 28496. It's all done percutaneously, meaning through the skin. They actually don't make a wide open excision. Areas of bones are important to know when we are identifying locations of fractures. There may be an open treatment of a proximal fibula fracture, 27784. Proximal means closest to your body. Distal fibula fracture, 27792, furthest away from the body. So yes, it's the fibula, but we need to know, is it the proximal or is it the distal? And that happens with the radius, the humerus, tibia, and fibula as well. The coding shot. If a physician attempts a reduction of a fracture but is unable to align it, we can still report the reduction service. List the attempted reduction service and then list the more involved fracture care with a modifier 58. So just because your physician attempted to reduce it and wasn't able to do it doesn't mean you can't bill it. Real important, because a lot of times my docs will attempt to reduce the fracture, they don't reduce it, and they schedule the patient for surgery, and they bring them to the OR, and they don't even tell me they attempted a reduction. Right there, they just lost themselves about $300. So I had to stress the importance of, even if you try and you didn't do it, it is billable, so that we can hopefully get something back for them. When we talk about traction, traction is the application of pulling force to hold that bone in alignment. Skeletal traction is internal devices. So this is the pins, the screws, the wires. They are inserted into the bone through the skin with the ends of the pins, screws, or wires sticking out. And that way they can attach traction devices to them if needed. Skin traction can be strapping using elastic wrap or tape fastened to the skin or wrapped around the limb. Then you can apply weights if needed, and if you look on page 420, you will see the distal and the proximal portions of the fibula there, or tibia. And then an example of the traction. So with the leg, they are pulling the bone to hold it in alignment. And a different type of skeletal traction where they're using weights attached to it. And then just simply wrapping or taping is another means for traction. On 421, dislocation. Dislocation means that the bone is not in its normal alignment. It is displaced. Treatment of the dislocation means we are going to return that bone to its normal location. And this can be done, again, by a variety of methods. Sometimes it's just a push, a pop, and it goes back in. Other times it may administer digital blocks, especially for the finger. They apply gentle traction until the finger falls back into place. Then they would put a splint on it and wrap it to keep it immobile for about 3 weeks. If your shoulder's dislocated, physician might elevate your arm, rotate the humerus while applying pressure to the head of the humerus, or patient can lie face down on the table with your arm hanging off and a weight attached. And sometimes that weight is enough to pull that back into place. I've seen somebody dislocate a shoulder, and without medical advice, the person was not too bright to begin with, but what they did is their shoulder was dislocated, and they took and walked into the side of the doorway as hard as they could, and they actually popped their shoulder back into the socket by just hitting the door frame. Probably not the best way to do it, but there are ways it can be done. So again, dislocation means it is not in its normal position. Look on page 422 and look at number 4. We have an open distal fibular fracture with internal fixation. Open distal fibular fracture, internal fixation. What's your key word? Where are you going to start looking these up?
Fracture?
Very good. Let's start with fracture. Open distal fibular with internal fixation. So we're going to fracture, and then what's our next word, do you think?
Fibula?
Fibula? Okay, great. Once you're under fibula, is it an open or a closed treatment?
Open.
Okay. Do you
So-
see some codes?
Yeah. Would you just go under open treatment?
Yes, because if you look underneath it or above it, the one that's above it that says open treatment is only pertinent to bimalar. The
Yeah.
one underneath that says open treatment is pertinent to the shaft.
Yeah.
So yes, those codes under open treatment, 27784, 27792, or 27814. And again, when you're taking the exam, you can use a ruler to put in to hold your spot out back when there's more than one code like this, or put your hand so that you can flip back and forth. So 27784 is the first one. Let's take a look at that one. That first one, 84, does that work?
I don't think so because it doesn't say distill.
Right. This is proximal. It's not distal. So let's get rid of the 84. Let's check the next one, 27792.
I don't think so because that says lateral.
But look what's before it, an open treatment of a distal fibular fracture. And then in parentheses it says lateral malleolus. So what that is telling us is your lateral malleolus is also referred to as your distal fibula.
Oh, okay. And
Okay?
yeah, this is the one.
Right, because look at 27814. And that one says bimalar ankle. So that one is not it. So yes, it would be 27792. And if we knew whether it was right or left, you would put LT or RT. What about number 8? Closed treatment, closed mandibular fracture, including interdental fixation. So closed treatment of a mandibular fracture. You still going to that word fracture, right?
Mm-hmm.
And then what?
Then closed.
What's the body part?
Oh, sorry, mandibula. I was already
Okay.
at that. And then closed treatment. Two, 1, 4, 5, 3.
Right, under fracture mandible, we've got closed treatment, and under that, we've got interdental fixation with manipulation or without. And this clearly said interdental. So let's go 21453. And again, let's read it and make sure it is what we are looking for. Closed treatment of mandibular fracture with interdental fixation. Yep, that is correct. So again, when you're doing the fractures, fracture would be your keyword, and then the body part, and then if we know whether it's open or closed, that's where we go from there.
If you did the ICD-10 code, would you do the same kind of process, like go to fracture and then... The CPT for me seems a lot easier. The ICD-10, I feel like I get lost doing it.
I don't have my ICD-10 book with me, but yes, do you have yours with you?
Yeah.
So go ahead and pull out your ICD-10 book, and let's go to the word fracture. Because what we would be looking for here is not the procedure, but the type of fracture. So we would be looking for a diagnosis code for a closed mandibular fracture. So let's go to the keyword fracture.
Oh my goodness, I hate this book. Okay.
And then is there anything listed under mandible or mandibular?
Well, they give you like fracture, pathological, traumatic. So, let me see.
So would not be this would not be pathological. This would be a traumatic fracture.
Okay. Okay, mandible.
So what does it give you in the list once you found fracture and mandible?
It says alveolus, angle, body unspecified, condylar process, coronoid process, ramus unspecified, specified site, subcondylar process, and symphysis.
Okay, but after the word mandible, is there a code after just the word mandible or mandibular?
Yes.
Without knowing any more specific about it.
Yeah, S02609.
Okay, so let's go look that up in the tabular and see if that is just a straightforward closed mandibular fracture. Because when you're looking up stuff in your ICD-10, you're looking up not what was done, that's your CPT. Your diagnosis is why it was done.
This what did I say? S0 2.609. Okay, fracture of mandible unspecified.
Okay. And that is fine for us to use. Does it say anything about it being a closed fracture?
Not on that, no.
Okay. As long as it doesn't have one that you could choose if it was open or one that you had to choose if it was closed, that you would want to be careful of. But the reason it is unspecified, and that is fine for us to use, is because we don't know what part of the mandibular was fractured. If your physician goes on to give you that specific information, whether it was the alveolar or whatever those other ones were, then we may be able to be a little bit more specific. But otherwise, that would be absolutely fine. Yep.
So when we're doing the ICD-10, all we're doing is trying to find the specific, let's say,
Problem.
body part. Yeah.
Yep. So why were they seen? So was it diabetes? Was it a fracture? Was it abdominal pain? That type of thing. Yep. So the CPT is what did we do, and your ICD-10 is why did we do it. All right. So the first subheading in your musculoskeletal is general. So this is miscellaneous procedures that may not be specific to an anatomic site. With that, the first code, again, and if you follow in your CPT book, that code would be 20005. And this just says incision and drainage of soft tissue abscess, subfascial, which involves soft tissue below the deep fascia. There are codes in the skin or the integumentary system for incisions that are skin only. But what makes this 20005 different from the integumentary code is that it is in the deep tissue. It's not in the skin. So again, this is where reading comes in as well. We need to know if it's strictly on the skin level, it's going to be an integumentary code. If it's deep tissue or muscle, it's going to be in a different section. Wound exploration, 20100 to 20103. Traumatic wounds resulting from a penetrating trauma, gunshot, knife wound. The wound exploration includes basic exploration and repair of the area. These codes are used when the repair requires enlargement of the existing wound for exploration, cleaning, and or repair. Included in wound exploration codes are not only the exploration and enlargement of the wound, but also debridement, removing foreign bodies, ligating minor blood vessels, and repair of subcutaneous tissue, muscle, fascia, and muscle. So again, in that gunshot wound, if they're going in and they're removing out that bullet and the little shrapnels, that's all going to be part of that bullet removal code or that wound removal, wound exploration code. If the wound does not require enlargement, then we report a code from the integumentary skin repair section. If the wound is more severe than a wound exploration, the repair code would come from the specific repair by anatomic site. Again, careful reading the medical record to ensure we are in the correct area so we can choose the correct code. In the case of the bullet wound to the chest, again, that wound exploration would be included in that thoracotomy or opening up that chest cavity to get that wound out. So again, depends on how they are removing. Excision, 20150 to 20251, biopsies of muscle and bone. These are divided based on the type of muscle, or the type of biopsy, muscle or bone. The depth of the biopsy, is it superficial or deep? And then how did they obtain the biopsy? Percutaneous needle. And you'll see if you look in your CPT book, it clearly says under code 20206, biopsy of the muscle, percutaneous needle. If you look down further, it says if you used a fine needle aspiration, it takes you to a code from the integumentary system. If you excised the muscle or the tumor, see the specific anatomic setting. So it will lead you to other areas if that is not what you are looking for. The procedure for a muscle or bone biopsy includes local anesthetic. incision into the area following exposure of the muscle or bone, removal of tissue for biopsy, and suturing the area. That would all be included in that biopsy code. A percutaneous biopsy means it is not opened to the physician's view. So they're not making an actual incision and opening the skin so that they can see what they're removing. They're doing it through the skin. So they go in through the skin and they suck it up through a little needle. When the percutaneous method is used, the area does not require suturing. It can get more difficult, so if the biopsy is complicated, they may need ultrasound, which you can additionally use. You can code that from the radiology section if there are imaging guidance used during that procedure, and a lot of times it will tell you underneath as well. If ultrasound used, see codes, and it will tell you what those codes are. Biopsy codes in the excision category are not to be reported for excision of tumors of muscles. If the medical record has excision of a muscle tumor, we have to choose a code from the musculoskeletal system. So for example, 24071 is excision of a tumor 3 centimeters or more from the soft tissue of the upper arm or elbow. And the biopsy codes do not include pathology. Your pathologist is going to bill for the reading of that tissue sample, not your provider when he takes the specimen. General introduction or removal. These codes start 20500 to 20555. This is injection, aspiration, insertion, application, removal, and adjustment. Sinus tract injection procedures are in this category. Typically, you would think of nasal sinuses when you hear sinus tract, but these are not. Sinus refers to a cyst or abscess inside the body with a tract, which is known as a fistula. So with certain sinus injections, the radiologist will use ultrasound guidance to make sure they have placed the needle in the correct location, and that using of the ultrasound guidance can be billed in addition. That can be reported separately. Other methods that may be used in treatment of the sinus tract are incision or opening the tract, which is called a fistulotomy, to promote healing, or a fistulectomy, which is an excision. Removal codes 20520 to 20525, removal of a foreign body lodged in a muscle or tendon. Now we did have foreign body in the integumentary system as well, but that was foreign bodies in the skin. This would be foreign bodies in the muscle and or tendon. Injection codes in this section report injections made into a tendon, ligament, or ganglion cyst. So we use this in our office for cortisone injections, people with osteoarthritis, and they get injections into their joints. Read carefully the notes after the codes. For most injections, 20550, 51, and 53, the description states injection or injections with an S after it. That means that one or more injections can be reported with the same code with no modifier. Code 20600 to 20611, arthrocentesis, aspiration of a joint. The area over the involved joint is injected with an anesthetic. They insert the needle and they withdraw fluid. New codes for arthrocentesis procedures were created, including ultrasound guidance. So if you look at some of the codes, we have 20604, 06, and 11, which include ultrasound guidance. And then we have 20600, 05, and 10, which is not using ultrasound guidance. So again, real important, because not using ultrasound guidance might be, let's say, $125. Using ultrasound guidance might bump it up $50. So every time you miscode that, you could be losing money for your provider. 20612 reports aspiration and or injection. So when it says and or, it doesn't matter if it's an aspiration or an injection. That code is used for both of them. And or injection. The treatment of a ganglion cyst is surgical removal, aspiration, or aspiration with injection. Sometimes they are in clusters. If multiple cysts are treated, we need to report 20610, which is the ganglion cyst code, with modifier 59 to say that we are doing multiple cysts, so to speak. With the aspiration and or injections, the codes are divided based on whether the joint is considered small, which would be your finger or your toes, intermediate, which would be an example of your ankle or your elbow, and major would be your shoulder, your hip, or your knee. So while the shoulder is a major joint, within your shoulder you have what we call the acromoclavicular joint, which is part of the shoulder, but that's only an intermediate joint. So the shoulder itself is a major joint, but that AC joint is considered intermediate. So if my physicians specify that they inject the AC joint, then I have to code it as a medium or an intermediate joint. If they inject something else in the shoulder, then it can be billed as a major joint. Again, they are also divided by with or without the ultrasound guidance. Lidocaine, Marcaine, these can be used as anesthetics. With the injections, they are not reported separately. It is part of the code, but you would bill, in addition to the aspiration and or injection code, the medication that you are injecting. So that corticosteroid that you are injecting, as long as your office has purchased it, you would use a code from your HCPCS book, a J code, for that medication so that you get reimbursed for it. Insertion of wires or pins to repair a bone, 20650, is a procedure used by orthopedic physicians. Typically uses local or general anesthetic. The bone is drilled. Pins or wires are placed through the holes in the bone. A traction device is then attached while healing takes place. And I don't know actually why, other than they're talking about the insertions of wire and pins, that they put that back in there, because we talked about that one already. On 426, removal of external pins, wires, is included in the reimbursement for fixation. So if they put a pin or a screw on the outside when they manipulate that broken bone, when they go in to take that pin or screw out, if they're just taking it off from the outside and pulling that pin out or whatever, that's part of that initial fracture care or the repair. But if it's internal device and they have to take that patient back to surgery and open them up to remove those, that would be billable. 20670 and 20680. And if you look at that, the only difference between those two codes is the 20680 is for deep and the 20670 is superficial. So it depends on how deep those pins or screws or wires are. Codes to report application of devices for the fixation of bones. For example, we have cranial tong, cranial halo, pelvic halo, femoral halo, caliper, stereotactic frame. These are all in this section. Each application includes removal of the device unless a different doctor removes the device. So if your doctor is putting on, if you look in your CPT book, 20664 is a halo application. If your doctor puts that on and removes it, we can only code for the putting it on. The removing it is already part of that code. Each, again, of the application includes removal of the device except for another physician. When application of the devices is performed through an open surgical procedure, it is referred to as open reduction with internal fixation, ORIF. You see that a lot. We talked about the removal codes, 20670 and 20680. Those can be for removal of buried wires, pins, rods, anything that is implanted. So a lot of times they're put in until it heals and then it's meant for them to come out. Other times they're meant to stay in there and they'll stay in there indefinitely until they cause a problem. So sometimes as years progress, somebody can get pain from those pins and screws that are left in place, and that can be a reason for them to go in and take it out years down the road. External fixation is the application of a device holding a bone in place, but unlike internal, the device is placed on the outside of the body, and the pins and wires are placed into the bone from the outside. So they're fastened to the bone and they hold the bone immobile. This type of fixation is used with comminuted fractures or fragmented fractures that might be difficult to hold in place. 20690 and 20692 report whether the device is placed on one surface, which is called a uniplane, or several surfaces, which is called a multiplane. So a uniplane means that two or more pins are inserted above the fracture site and two or more below. And the multiplane are more complicated, which definitely makes sense. So you can take a look in your book and you can see a uniplane and then a multiplane. And again, the multiplane ones are much more complicated than a uniplane. If you look on page 427, note that most of the codes in this section are for unilateral. So again, if we are doing it on both sides, we need to use that 50 modifier. If the device is adjusted, it can be reported separate, 20693. The removal of external devices is usually accomplished under anesthesia, and if it's done under anesthesia, we can bill it with 20694. If the removal does not require return to the operating room, we cannot bill it separate. It is bundled. If it's removed outside the global period, then you can bill it as an office visit. So that global period, if you remember the surgical packages, the global period right now for a major procedure is 90 days. The AMA, the American Medical Association, is looking into switching that from 90 days to 30 days across the board. Because 90 days, providers are going longer, they may not be seeing the patients, therefore they're not getting paid, but after 30 days, if they needed to come back, they figure by 30 days with the technology now, especially where a lot of it is done laparoscopically, 30 days should be able to cover that operative period. So look at number 2 under 15.2, replantation of right foot after a complete traumatic amputation. So we're doing replantation of a right foot after amputation. So what's the key word there?
Replantation.
Replantation, yep. And then the body part.
Oh, okay. Foot.
Foot.
What you said?
And where does that lead you?
20838.
20838. So let's go see what that says. Replantation, foot, complete amputation. So that is what we're looking for, correct?
Yeah.
And we know what foot it is, so you would add the RT modifier. But again, right underneath this, it's telling us if we're looking for a reimplantation of an incomplete amputation, it tells us to see codes for repair of bones, ligaments, whatever. So kind of guiding us that, wait a minute, if you're not sure it's a complete amputation, you may want a different code, which I think is nice. What
Karen,
about
when you
number 6? Whoops, sorry.
Nope, that's okay. When you said 30 days, the AMA is looking to change the global period to 30 days across the board.
Yep.
Across the board, is that for minor and major procedures? Okay, all right.
Yep. I don't know whether they will get that through or not, because right now your minor procedures are 10 days.
Or 10, right.
And the major procedures are 90. So for them to
Right.
kind of all go to 30, maybe what they're thinking is the major surgeries go to 30 and maybe the minor surgeries, they take away the global period. So we'll see. It's in the works, and it's not anything that has been firmed up for 2018, so it's not in the immediate future, but it has
Right.
been mentioned on numerous occasions at the AMA meetings, so we'll see what happens. What about
Thanks.
number 6? Intra-articular aspiration and injection without guidance of a finger joint. Aspiration and injection without guidance, finger joint. Where it says primary osteoarthritis, Jessica, that would be your diagnosis. So when you went to your ICD-10 book, you would be looking up osteoarthritis of the finger.
Okay, so that's the problem, and then what we're going to do about it is what
The
we're going to.
aspiration and injection. Yep.
Okay. So finger.
So you're going to start with finger.
Yeah. I'm going to. So I'm looking for finger joint. Okay, so joint, aspirate. Oh, wait.
Finger joint, and then you've got aspiration and injection. And if you look at both of those, they lead you to the exact same codes.
Okay, I was looking. I'm like, they don't have both.
Uh,
Okay, so 206.
so it leads you to either 20600 or 20604.
It would be 20600.
00 because it's without ultrasound, correct?
Yeah.
Yep,
Right.
you got it. 20600. Arthrocentesis, aspiration and or injection. So it doesn't matter if you do one or both. You can't bill it twice. Small joint, and then it gives us example fingers and or toes. Good. Okay, the next section is grafts or implants. 20900 to 20938, harvesting bone, cartilage, fascia, tendon, or tissue through an incision separate from the one used to implant the graft. So sometimes a tibial fracture may not heal in a certain period of time, and the physician may decide to do bone grafting to help that heal. Bone grafting is used for large defects, typically over 6 centimeters, and some types of fractures commonly heal with difficulty. So after debridement, if there's no healing within a week's period of time, then they would decide to do grafting. Grafts are obtained from a patient or donor. Donor can be living or deceased, which is a cadaver. Pieces of bone are shaped into bars or pegs and then used to repair the defect. There is something called fascia lata grafts. These are taken from your mid-upper lateral thigh because that's where that area is the thickest. And codes for obtaining the fascia lata graft are based on whether a stripper, 20920, removed that fascia, or a more complex removal, 20922, was used to get that material. Tissue grafts, obtaining of fat, dermis, or loose connective tissue from the tendons. Spine surgery, 20930 to 20938, obtaining and shaping the tissue. Again, if it's from your patient, it's an autograft. If it's from a different donor, it's an allograft. Obtaining and shaping of spine graft material would be reported in addition to the implantation. So we'd have the implantation as the primary procedure, and then we would have the graft as an additional procedure. Some other procedures in the 20950 to 20999. Monitoring muscles, bone grafting with microvascular technique, osteo flaps with microvascular, electronic ultrasound stimulation, and computer-assisted procedures. So 20950 is monitoring interstitial fluid pressure. So they put a device in the muscle, and they can measure the pressure change within the muscle. They can see how much fluid and if it's causing the blood supply to be compromised. This is done because if there's fear that the blood supply is going to be compromised within that area, the muscle will die. So they could lose function of that limb. Bone grafts, 20955 to 20962, identified by the site from which the graft is obtained. So when the bone grafts are removed, the blood vessels remain attached to the graft. That way they have blood supply. This is done using an operating microscope. And there is a code, 69990, for an operating microscope. So if your physician does something and you hear the terminology operating microscope, that is something you can bill in addition. It doesn't get you a lot of reimbursement, but if they're doing it 10 times a week and it's an extra $25, it'll add up fast. You will note that that operating microscope is included in some codes, 20955 to 20962, but there are also codes that will say if operating microscope used, please bill separately. So again, watch the wording. Free osteo flaps, 20969 to 20973. Bone grafts including skin and tissue overlying the bone. So they have an arterial pedicle that's attached to the artery, and then they use the skin, tissue, and bone to reconstruct the defect, again using that operating microscope. And then the codes are divided based on what part of the body that the flap came from. 20955 to 20962, vascularized bone grafts. These are typically used for large defects or long bones. Electrical or ultrasound stimulation, 20974 to 20979. This promotes healing. So some people with fractures, the fracture doesn't heal in a specific amount of time. Sometimes an electrical or ultrasound stimulation is used to help that bone heal. We have used it a few times in elderly patients with that underlying osteoporosis, where it takes a little bit longer for things to heal. Computer-assisted surgical navigation, 20985. Navigational assistance in a musculoskeletal procedure with a computer. We don't have that technology up in this area, but some of the bigger facilities, it is possible that that would be a code that could be built. We then go on to spinal instrumentation and fixation. These codes are based on the area in the vertebral column or your spine, 22010 to 22899. They are based on cervical, which is C1 to C7, your lumbar, L1 to L5, and your thoracic, T1 to T12. So again, codes ranging 22210 to 22216 identify osteotomy, so cutting into the bone in cervical, lumbar, or thoracic area. Codes are divided based on exact spinal location. So if you look at 22590 to 22600, this is arthrodesis of 3 different cervical areas: occiput to C2, C1 to C2, or cervical below C2. So again, reading the notes to make sure we know what area. In your CPT manual, C1 you will hear referred to as the atlas and C2 as the axis. So C1 is the atlas, C2 the axis. On 429, arthrodesis can be done with another surgical procedure such as a fracture or a laminectomy. If arthrodesis is done with a more major procedure, use modifier 51 on the arthrodesis to indicate multiple procedures. An exception to this rule is when the code is an add-on code. So in your CPT book, normally if we do more than one procedure, we typically would put the modifier 51 on the lesser of the procedures, unless there is a plus symbol next to it in your CPT book. That already indicates it's an add-on code and you would not use your modifier 51. I will tell you they will try to trip you up on that on the exam. You'll have codes that have the plus symbols, and one of your answer choices will have the modifier 51 on it. And you need to know that you can't put 51 on a plus code. Spinal instrumentation used to stabilize the spinal column in some repairs. Segmental instrumentation attaches a fixation device at the end of each area being repaired, and at least one other attachment in the spinal area being repaired. So if we had a repair at T1011, a rod would be attached to T7 and L1, and a repair rod may also be attached at T8, 9, 10, 11, and 12. So again, it depends on where the repair is taking place. Non-segmental instrumentation is application of the fixation device at the end of the area being repaired. So if the repair was at T11, the rod may be attached at T7 and T12 only. So just in one area instead of both. Most of the instrumentation codes are add-ons, so again, they are reported in addition to the primary procedure. After the spine, we move on to foot and toe repairs. Common procedure on the toe is hallux valgus, which is bunion surgery. Hallux is your great toe. Valgus is the angulation of the toe away from the midline. And if you flip to the next page, there's a picture of hallux valgus on 15-16 figure. Variety of procedures done to correct the defect. These are in codes 28292 to 28299. Keller procedure is a common one that falls under 28292. They put a wire through the bones of the toe to hold it in correct alignment. Each code description indicates the type of procedure that is included, many which are eponyms or names of individuals. So again, we need to know the type of bunion surgery that they did if it was a particular one, so that we pick the correct name. Applications of cast and strapping, 29000 to 29799. These are for initial and subsequent treatment of fractures, sprains, tears, and overuse injury. They can be reported for initial stabilization. Because each injury is unique, each cast is unique because of size and possibly position. So a cast immobilizes the fracture. They use plaster, fiberglass, thermoplastic. Plaster is kind of gone out and fiberglass is more the in thing. But the thermoplastic is pretty cool. We have an easy bake oven is what we call it. And the cast actually goes in the easy bake oven. And it heats up and then you put it on. We use the wrist ones. You put it on the area and you mold it to that person's body part. So a couple of different types of castings. Strapping is taping of a body part, and you can see different ways to do that up at the top of 431 depending on the injury. It gives it more stability. And taping typically is for sprains, strains, and dislocations. Splints can be made of wood, cloth, metal, plastic. These also immobilize, support, or protect the body part so that it can heal. And again, removing a cast or strapping or splinting is included in the initial placement of that cast or strap or splint. So you put it on, you take it off, it's one code. You put another one on, take it off, it's another code. But that removal is included in that initial placement. You can see the coding shot if a cast, strapping, or splint is applied as part of a surgical procedure. Do not report codes from the application of cast and strapping because the musculoskeletal surgical procedure, remember I said for that fracture, includes the initial cast. So we would not bill it separate. If cast, strapping, splint is applied as part of a fracture repair, again, we do not bill it separate. The initial is included in that fracture code. But if we do a subsequent cast or splint, we can bill the subsequent with a modifier 58. And if we use additional supplies above and beyond what would normally be used, you will see that additional supply codes are in your HCPCS book, and they range A4580 to A4590. The code descriptions for the additional supplies depend on whether it's casting material or strapping or splinting material. Modifier 25, if your patient comes in the office and you see them for an office visit and you decide to put a splint on, then a modifier 25 would go on your office visit so that you would get paid for both your office visit and your splint. Because if you look it up, your splint is actually considered a surgical code. So if you try to bill your splint with your office visit without that modifier, they're going to pay you for one or the other, and it's typically your office visit because that's the one that's less. You can report application of casting and strapping when the physician applies initial cast, strapping, or splint for definitive treatment by another provider, or applies a subsequent, treats a sprain or fracture and does not expect to do surgery, for example. And your applications of cast and strappings are divided into 3 categories: body and upper extremity, lower extremity, and removal or repair. And when you go to the upper and lower, it's cast, splints, and strapping, because those are 3 different things. They're based on location of the cast, splint, or strapping, and often what type of splint or cast, such as fiberglass or plaster, whatever it happens to be. Look on page 432. Look at number 1. We have replacement during the global period of a fiberglass shoulder to hand long arm cast for a 54-year-old patient. So it's during the global period. So right there, that tells me we got to use modifier what?
25. Or-
No, 25 would be if it's on an
58.
office visit.
That's right.
58.
You're right.
Yep.
58.
Okay, so fiberglass shoulder to hand, which is also called a long arm cast. So let's see what we come up with for that. What keyword are you looking up?
Would you look up, it says, shoulder to hand.
We're looking for a code for what? A cast?
For replacement. So we would look up replacement?
I went to replacement. I didn't find anything. So I went to cast.
Oh, just to cast? Okay.
Yep, just a cast. Once you're under cast, you're looking for either a long arm or a shoulder to hand.
I think we would just go right to shoulder to hand because the long cast or long arm is under ambulatory. So
Okay.
I think we would go there.
Actually, if you look at both, it's actually the same code.
Oh.
But yes, I would definitely do the shoulder to hand as well because it's listed first. So let's go check that out. It's 29065. And let's see how that is worded. Make sure it matches.
cast, shoulder to hand, long arm.
So that is correct, right? So we'd have 29065 with a 58 modifier because it's during the global period. So we want to make sure that we specify why we want to get paid for it. What do you think that second line's for? Because
The age.
the what?
Would it be for like the age of the person?
Nope.
No.
If you look at number 5, it also gives you a second line. What I don't like about this is they're not giving you specifics about this. But if you look at this one, it's shoulder to hand, so it's a long arm cast. If you look at number 5, it's thigh to toe. What they're wanting to kind of stress to you is that these two replacement or cast codes may involve additional supplies. So your physician, one, would have to tell you that he used additional supplies on that shoulder to arm cast. But if they did specify that they used more wrap than normal or whatever happens to be done, you could use either a additional A code from your HCPCS books for the actual supply, or there is a generic supply code that is 99070 that you can use when you bill additional casting supplies. The only problem with the 99070 code is if you do not specify to the insurance company what that additional material is, they don't know what to pay you. So you would actually have to add a description on your claim form that says 3 additional rolls of plaster, let's say, for example. And then you set your fee or set your amount for that particular one. So it's easier if you can find a specific supply code in your HCPCS book for that roll of plaster or that roll of fiberglass. But if you cannot, you can use that generic 99070. And if you look in the back of your book at the answers, that's what it specifies to you. It says if you know the specific material, use an A code. If not, use the 99070 code.
But if you wouldn't have told us that, we wouldn't have done it because it doesn't say, like, I feel like it would have said cast with.
Right. And that's exactly why I point that out, because
okay.
if I didn't tell you, you are absolutely right. You would not know it was additional material. What they want you to think about is that it's a long arm or a thigh to foot. So they're trying to get you to think that that probably would use more material than normal because it's a very large cast. But again, without telling you, I wouldn't have known either. So that's why I kind of do those ones so that you will have an idea.
Okay.
Endoscopy and arthroscopy. Orthopedic surgical procedures are often done by arthroscopy, so they are small incisions which reduce your risk of infection and make recovery time much, much less. And through those small incisions, they put the scopes and the mirrors and all the tools that they need and do it right through. And you can see on the bottom of this page, they're doing a scope of the knee through those small incisions. The arthroscopy codes are at the end of the musculoskeletal system. If multiple procedures are performed through a scope, again, your multiple or less arthroscopy codes would be used with a modifier 51. Now, if you look at that next line after that modifier 51, it says bundled into all surgical procedures are or include the diagnostic. The best way I can tell you that is if your doctor goes in and looks and he finds something that he needs to repair, you are going to code the repair. the go in and look goes away. Because if he goes in and finds something, you now have something to fix. So you're going to code the fix. You are not going to code the go in and look. The go in and look is already part of the fix. So anytime you see that throughout the upcoming chapters, a go in and look or a diagnostic is always included in the surgical. A note preceding endoscopy codes 29800 to 29999 state when it's done in conjunction with arthrotomy, add modifier 51. That indicates that if the surgeon performs an arthroscopy and during that procedure ends up cutting in instead, so he's done the scope, now he's actually going to make an incision, take the scope out, and go in another way. Both services can be reported. You will see it gives an example of a physician going in and doing a shaving of cartilage and doing an open capsulotomy of the knee. Both the shaving, 29877, and the capsulotomy, 27435, would be reported. Your least expensive procedure would have a modifier 51. What happens here is when you bill multiple procedures, if you do not bill your most expensive procedure first, and you bill your cheaper one first, and then you put the modifier 51 on your most expensive procedure, unfortunately the insurance company is not going to put that in the correct order for you. So they're going to pay you on your cheaper procedure 100% of the allowable, and then on your most expensive procedure, because you put the modifier 51 on that, they're going to pay you 50% of the allowable. So if you figured it out both ways, you end up sometimes, depending on the cost of the procedure, losing $500 or more because of the order that you put your procedures in. A lot of your practice management systems will put your CPT codes in that order for you, the most expensive to the lowest. Other times you have to mess around with it once you enter them in. When coding arthroscopies of the knee, note basket forceps rather than shaving and debridement. So basket forceps is catching it and pulling it out in a basket. Shaving and debriding is different. So again, watch the wording. Codes in arthroscopy are divided based on body area, elbow, shoulder, and knee, and then the extent of what we did. So did we go in and look? Did we remove foreign bodies? Did we repair something? So 29805 is a go in and look for diagnostic. And 29806, we actually did a surgical repair on that shoulder. So again, go in and look, or what did we find and what did we fix? If a procedure begins as diagnostic and converts to a surgical, we code the surgical. We code what we did while we were in there. The go in and look goes away. Again, that coding shot, diagnostic, always included in surgical. If you look at the description for 29805, you will see it says arthroscopy, shoulder, diagnostic, with or without synovial biopsy. Separate procedure. Separate procedure you will see a lot. What that means is you cannot report the service of a minor procedure unless it has been performed as an independent service addressing a distinctly separate problem. Also note the parenthetical information indicates codes 23065, 23066, 23100, and 23101 are to be reported if the procedure was done as open, which means incisional, instead of endoscopic. So you'll hear me talk more and more about separate procedure, but if we see something that has the word separate procedure after it, if it's the only thing we've done, then fine, we can bill it by itself. But if we have two separate codes that we come up with, and one of them says separate procedure, we have to look at it carefully to determine whether or not we can truly bill that, if it's truly different or a different body part, or if it's actually possibly part of what we're already billing with our other code. So be careful with, again, separate procedure. And we'll go, again, over that more. Look on page 434, and let's take a look at number 4, arthroscopic repair of a tuberosity fracture of the knee with manipulation. Arthroscopic repair, tuberosity fracture of the knee with manipulation. Where might you start on that one?
Knee.
Knee? Okay. Any other ideas?
I love it because I always know that it's wrong when you.
No, not that it's wrong, because remember, sometimes you're going to find it under more than one. And this is an example of probably one of those where we can find it a couple of different ways, actually. So you're going to knee. Let me try fracture. Tuberosity fracture. All right, let's see.
I think I would go to, well, I don't, this was probably a bad choice because it says arthroscopy and then you have surgical and then you have so many codes.
Okay.
So many.
So if that's the case, what I probably end up doing is go to that section and start reading. Because it does, it gives you a wide range of codes that we can select from. You went to knee, you said?
Yeah. Sorry, excuse me. Yeah, I went to knee and then I went to arthroscopy, and it either gave me diagnostic, which gives you only one, or surgical. Right. And I went to surgical because it says repair.
Okay. So that's one way you could do it. What about if we're doing a repair of a fracture? So look up fracture and knee.
Oh, it only gives you 2.
See, I think you could do it both ways. Your way originally is going to give you many more codes and make you work a little harder for it. By going to fracture and knee, you are absolutely correct. It's giving us 29850 or 29851. So now let's go look at that and see what those say. Arthroscopic repair, tuberosity fracture with manipulation.
So it would be 29850, wouldn't it?
50, right, because it says arthroscopically aided treatment of intracondylar and or tuberosity, in which case this is the tuberosity of the knee, with or without manipulation, so that covers the with. It says without internal or external device, which doesn't specify there, so that's great. And then underneath it says includes arthroscopy. So correct, 29850. So again, you could have found it by going to knee and then arthroscopy, but again, you would have had to have worked a little harder and read the description, more descriptions than just those 2. Okay?
Actually, you know what? That 29850,
Yeah.
wasn't even one of the options it was giving me.
That's right. It would have led you to the correct area because look in your CPT book and what's on
Yeah.
the next page, arthroscopy of the knee.
Yeah, but
So
that
it
could
led
be
you to
5
the right
minutes on the
area.
test. Could be a wasted 5 minutes on the test trying to read them all.
Right, exactly. But remember, on the test, they're already going to give you the choices. So yes, you have to read, but you're not looking at your alphabetical index to know that you have that many there that you would be reading.
Okay.
You know what I mean? Okay, so that is it for the musculoskeletal system. So you only have 14 minutes. So if it's okay with you guys, rather than start the respiratory, that's not a fairly long chapter. I'm going to wait, and next week we will do both respiratory, and then we will get started on the cardiovascular. That's kind of a long chapter, so that one may take us next week and possibly the week after vacation to finish up. But I'll try to get through both so that way you've got time over Christmas break to work on anything that's outstanding. So any questions in the musculoskeletal?
So you're just going to be recording the lecture for next week because we won't be here.
You guys are not going to be here, so what I'm going to do is I'm going to check with the other person. She did not log in tonight, so I'm not sure what's going on. If she planned on coming to class, then I will do the regular old lecture. If she's going to be absent, then what I will do is I will ask Amy if she wants me to come in and record. I absolutely will do that. If she says no, give them an off week and we'll do it on the other end. If I don't record next week, because let's say you guys wanted 2 weeks off, it just means that we're going a week later, into February than we normally would end. So I don't mind coming in and recording if she's going to be here, or even if Amy says, no, let's do the recording so that we're not making them go too far out into February.
And I don't know if I'm sorry, I don't know the other lady's name. I don't know if you feel the same way, but when I watch the classes, like if they're like, oh, we're not going to have class tonight, watch the one from the fall, or, I get that. I've gotten that a lot with my other one.
Yeah.
It's really is confusing and hard because where we leave off today,
Right,
if I
isn't
go,
the same
if I go
as
and
last
I watch
time.
week 8, I'm going to be like, what am I watching?
Right.
So it's hard when we go back. I don't love
Yeah.
it.
And typically, the only time that should happen is if there's a class and Amy wants us to stay on track so we're not pushing you too far into like the next semester.
Yeah.
Then we would ask that you listen to last time's lecture.
Yeah.
But otherwise, if I'm not able to do the class, and I think it's Dina, she can do the class, then obviously it's going to be a fresh recording. If I can't do it and Dina can't do it, then I always check with Amy and say, what do you want me to do? And I will voice that to her.
Yeah.
I'll let her know that, if something comes up and I can't do class and Dina can't, that it's harder for you guys to watch the last time's lecture because it may not always be at the same spot that we're in.
Yeah,
And she may just say, fine.
In my other class, they've missed probably 3 classes, and I've watched 4 different teachers in this short amount of time. I'm so confused with it that
Oh, yeah.
I'm just going to read it myself and not even watch the classes because I don't even know what's happening. It's all over
Right.
the place.
Yeah. So no, hopefully that will not happen, that it will not be one of us actually doing the class, so we'll always be current. But I guess, God forbid if something drastic happened, that is a possibility, but I will make sure to let her know that, it would be easier if we can either bump it out so that we always are staying current and you're not trying to find something that matches where we are. So that's good to know. So, all All right, well, if there's no other questions, I will let you guys go, and we will pick up next week with respiratory.
Awesome,
Right.
thank you.
Thanks, Karen.
All